The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and thank you for joining us. I'm Gary Swartz, the Associate Executive Director, American Academy of Home Care Physicians, and welcome to this afternoon's webinar, Compliance and Compliance Plan for Home Care Medicine Practices. And thank you for joining us and your colleagues for this important information. The webinar objectives this afternoon are to provide the legal context for a compliance plan, describe the home-limited patient population, the regulatory requirements for service, compliance plan elements, sources of areas of focus for a compliance plan implementation, benefits of a compliance plan and tools, describe Academy resources and next steps, and provide time for question and answer. And due to the amount of information, if we're not able to get through the entire presentation, the slides will be posted, and let's consider this a start of the work on compliance plan and specific information to assist you in your practices. And we'll be developing more resources as time goes on with the goal to have a compendium, an updated compendium of rules and regulations for home care medicine available for you at the annual meeting next year in May. So getting started, what is the legal context for compliance? There are a number of important federal laws regarding fraud and abuse that apply to physicians and other providers. These are the False Claims Act, the NA Kickback Statute, Physician Self-Referral Law, also known as Stark Law, Social Security Act, and U.S. Criminal Code. And violations of these laws may result in non-payment of claims, civil monetary penalties, exclusion from the Medicare program, and criminal and civil liability penalties. There are also state fraud and abuse laws that mirror the federal, and then they may also have their own nuance. So beyond what we go over this afternoon from a federal perspective, you do want to be aware that in your own states that you'll have fraud and abuse and also referral or mini Stark laws. One item we are going to cover in some detail is the Office of Inspector General Compliance Program for Individual and Small Group Physician Practices. This was developed and posted on a voluntary basis by the OIG for voluntary adaptation in October of 2000. There are also similar versions for other sectors of healthcare providers and entities, and they do have similar elements. This one reflects some flexibility in application due to the focus on the individual and small group practice. Also, an element of the Affordable Care Act from a couple of years ago was a provision that provided authority to the Secretary of HHS to compel healthcare providers and suppliers to implement a compliance program as a condition of enrollment in Medicare, Medicaid, and the CHIP programs. So this would have us go from the voluntary nature of the compliance plan and program mentioned above to a mandatory, an obligation to have a compliance plan up and running. So this information is timely, and regulations to enforce this provision will be promulgated in the future. Some focus is required on the Federal False Claims Act, and it protects the federal government from being overcharged or sold substantial goods or services. And under the Civil False Claims Act, no specific intent to defraud is required. So it's important to understand that in the definition of knowing in the False Claims Act, this includes not only knowledge, but also instances where the person acted in deliberate ignorance or reckless disregard of the truth or falsity of the information. The Civil Federal False Claims Act also contains a whistleblower provision that allows private individuals to bring lawsuits on behalf of the United States and the Medicare program, and to obtain a percentage of any recoveries, and that's known as qui tam provision. Whistleblowers frequently are current or ex-business partners, office staff, patients, or competitors. There's also a Criminal False Claims Act And the important takeaway from this information is that you cannot contract away or ignore information regarding coding and billing compliance, so you do want to protect yourself. The federal sentencing guidelines also provide for the benefits of a compliance plan, and they've been recently updated, and I just wanted to focus on the bottom here that there is the opportunity for sentencing reduction when compliance plans are in effect. Getting back to the standard of knowledge, again, this is know or knew or should have known. You cannot contract away liability. You cannot purchase insurance for it. As the individual clinician, in a relationship with a group or an institution, you want to assure that there are provisions for your review of how your services are submitted. So once you render services and document, and if you do the coding, you want to know that you want to have the right to review that those codes left the organization, absent your knowledge and involvement that they changed the way that you submitted them. And that's, again, from your perspective as part of a contractual or clinical relationship with a practice or a health system or managed care entity, et cetera. From the perspective of your operation of a practice or your management and leadership of a health system practice, health system-based home care medicine practice, you want to assure that there are provisions in employment agreements or independent contractor agreements that clinicians must document and code in compliance with regulations and standards. So again, this is the other side of the provisions, and you want to have rights to enforce the provisions that the clinician must, their documentation and coding must be in compliance. Regardless of which side you are on in the situation, and this may change throughout your careers, you want to ask questions when establishing the relationship if you do not see such provisions. We are familiar through our experience and information at the Academy of situations where practices and individuals did not have the opportunity to use the whole range of codes that are in the CPT manual for house calls. And this was done on a contractual basis, and they should have asked or have had the guidance, the legal guidance to have that changed or to not enter that relationship. Drilling down into the compliant house call. This includes elements such as the home-limited patient population and place of service. So we want to talk about the home-limited definition, the provider-patient relationship, and medical necessity for the visit. This slide provides the beginning of the Medicare Carriers Manual on the description of pay coverage and payment for house calls and the definition of description of home-limited. We see a requirement for physician presence, of course, in the that you're actually present in the beneficiary's home, and that under the heading of homebound status is the point that the beneficiary does not need to be confined to the home. The homebound status is a term of coverage and payment of Part A, home health agency services, as you know, and that is not the standard for your services. However, your services with the medical record must document the medical necessity of the home visit made in lieu of an office or outpatient visit. And you want to have that documented up in front of each encounter with the patient in the area of your HPI, history of present illness. Continuing with the home-limited documentation standards, we see that medically necessary provider visits are payable under the fee schedule when provided the beneficiaries in his or her private residence. And there's no requirement that the beneficiary must be homebound. So we do receive this question a lot, and we know that you are questioned in the communities about this situation frequently as well. And please know that this is the documentation and regulation that homebound status for visits to home-limited beneficiaries is not required. And then set out below is the criteria that does need to be met. And again, the medical record must document the medical necessity of the home visit made in lieu of an office or outpatient visit. And then it continues on with the different aspects that you do want to be aware of. The service must be of equal quality. The level of documentation needs to be sufficient, particularly because home visits can be paid at some levels at a higher level than on an office basis because your patients are more complex. You have to be the provider of record and responsible for managing the entire disease process addressed in the visit. Services provided to the beneficiary for the first time must be either requested by the beneficiary, his or her delegate, or another Medicare provider managing the beneficiary's care. So what Medicare is concerned about is solicitation of visits and beneficiaries being seen without their request to establish that patient-provider relationship or have one established on their behalf. Again, number 6 is that you have to have that ongoing relationship and the ability to provide follow-up visits with some exceptions. Your services cannot be duplicative or overlapping of the services on the same day of a home health agency. The same concepts continue through the page. There's no incident to opportunity as there is in an office setting. In the home setting, because that would involve two providers essentially in the same space at the same time, and that may not be clinically necessary. It wouldn't make financial sense as well. The next aspects describe wound care and when they're covered or not covered, and when they're being rendered by the home health agency. And that documentation to various beneficiaries through the day must stand on its own. The medical necessity of the visit for any beneficiary must be supported in the documentation. And each visit, which is part of an episode of care, must not exceed the frequency of service that would be expected by the acceptable standards of medical practice for any other site of service. As I'll describe later on, the Academy was asked to be involved in a prepayment and resolution of a prepayment audit process that was going on in New York and Connecticut. And as a result of that, we provided under the Public Policy and Practice Management Committees and leadership of Dr. Thaler, George Thaler, we provided a white paper to CMS medical directors that described the services rendered to house call patients, the status of house call home-limited patients, and the frequencies that could be expected and the great variation in that depending on the patient's status. And that material will be posted and available for you. So the importance of the provider-patient relationship. It's critical to establish and document as it's required under Medicare regulations, as we just saw, for coverage and payment. For the transitional care management services that are now available this year, only one provider can submit a claim. So it's important to be that, again, that provider, that primary care provider of record and acknowledged as rendering those services. For the complex chronic care services that are being discussed with CMS and were in the proposed rule this year, described as complex chronic care management services, again, effective for 2015. Again, only one provider will be able to submit a claim per beneficiary. So again, that relationship will be key. In future years, that should be 2017 for all physicians. The value-based payment modifier will be applied and based upon patient attribution. Shared savings programs, such as ACOs and IAH, also require patient attribution or consent. And then finally, the communication, the provider-patient relationship and the number of patients that are in your panel and see you as their primary care provider provides practice value, and that'll be valuable to you in your discussions with health systems, ACOs, hospitals, and potential acquirers and joint venture partners in the future. Moving on to the medical necessity for the visit. The Social Security Act and Carrier's Manual, as we'll see, pays for services that are considered medically reasonable and necessary for the diagnosis and treatment of the patient's condition. And more specifically here, there's a side-by-side of what's required under the Medicare program and what private health plans as a consortium have established. And again, we see that for Medicare, it's a diagnosis or treatment of illness or injury to improve the functioning of a malformed body member. And this is why it's important to describe, outside of the preventive services and the annual wellness visit, for example, the medical necessity of your visit to that beneficiary in their home, and why that's being made, again, in lieu of an office visit. And you can see the terminology that private health plans have adopted on the right-hand side regarding medically necessary or medical necessity. So with that background, we can move on to what are the benefits of a compliance plan. There are many benefits of a compliance plan when it's up and running. That includes an enhancement and development of a corporate culture, legal protection, quality assurance that is provided through the review and feedback mechanisms that provides for performance reviews of both clinical and non-clinical staff, and information can be gathered from the conduct of the audits and the research of issues. It also provides for revenue assurance, and it also, having a compliance plan in effect, will help you with relationships with external parties, as we'll talk about relating to payers in a moment. Going back to that OIG plan for individual and small practices, what are the elements that they set out that to be established for a compliance plan? And we can see there are 7 elements: internal monitoring and auditing, compliance and practice standards, designation of a compliance officer or contact, the conduct of appropriate training and education to respond appropriately to detected offenses and develop corrective action, to develop open lines of communication with employees, and to enforce disciplinary standards through well-publicized guidelines. And then we'll discuss these in turn. One thing that the OIG mentioned in this 2000 compliance plan publication was that they're understanding that individual and small practices do not have the resources and scale of larger practices and entities, and that's why they developed a particular one for smaller practices. So the idea is that there's an effort made to address areas of concern, and it wouldn't necessarily be problematic if any particular element was not in place, or the way that the practice is accomplishing something is fitting for the practice itself, because it's their expectation that this is not one size fits all. So conducting internal monitoring and auditing. You want to conduct standards, and you have an option here. You either can conduct a standards and procedures review to assure you are current with coding and related regulation, or you can conduct a claim submission audit itself, beginning with a baseline, and then focus on problem areas such as denied claims. This can be done retrospectively or prospectively. I favor the prospective development of audits and moving forward in the baselines. And as the OIG says, once you've done some training, you should provide yourself a few months after that education to perform that baseline audit. And what you want to look for that is to see in this grouping 4 that claims are accurately coded, that documentation is completed correctly, services were reasonable and necessary, and whether incentives for unnecessary services existed. And then once the baseline audit is established, there is then the expectation that there be an annual audit process thereafter. Implementing the compliance and practice standards. You want to establish written standards and procedures with reference to risk areas. You want to update clinical forms and identify any clinical protocols that are relevant to your coding and documentation and clinical throughput, and then as it relates to coding and then claim submission. You want to incorporate standards of related, you have the opportunity to incorporate standards of related organizations such as a hospital partner or a revenue cycle vendor. So if they have an established compliance plan, as they will, then you may want to take a look, and you may already be interacting and using elements of their compliance plan. You want to incorporate any related federal communications that you receive, and newsletters, alerts, or any particular communication to your practice into a compliance binder. You want to identify risk areas of coding and billing, and again, those reasonable and necessary services, documentation, and improper inducements, and just be aware of what the risk areas to your particular practice are. One aspect is there's a prohibition of the routine waiver of coinsurance, and there are federal difficulty sort of exceptions to waiving coinsurance, but that should be documented on a beneficiary by beneficiary or patient by patient basis. You want to establish records retention standards and procedures, and also standards for your compliance record retention. Designating a compliance officer or contact. That's the next element, and you can also apportion the responsibilities of what would be in a compliance officer or contact across staff members. The compliance officer role has and that can also be outsourced, would have the elements below. That individual or that role includes overseeing and monitoring the compliance program, establishing audits to improve efficiency and quality of services and reducing vulnerability, periodically revising the compliance program, developing, coordinating, and participating in training related to the compliance program, and assure that training materials are relevant and appropriate, monitoring lists of excluded or debarred parties from the federal programs, the Medicare and Medicaid programs, et cetera, from employment with your practice, and then to investigate reports of possible improper practices and to monitor subsequent corrective action, compliance, or both. The conduct of appropriate training and education. Again, the individual would need to determine who needs coding, billing, and compliance training, the type of training, and the frequency and the mode of delivery of that training. You want to ensure that employees understand how to perform their jobs in compliance with practice standards and regulations. And this relates to onboarding or recruitment and hiring employees, clinical and non-clinical and clinical alike. You want to ensure that employees understand that continued employment is conditioned on compliant performance. And then that gets back to some of the documented provisions in relationships and in policies and procedures manuals and orientation, et cetera. And that brings us to, you do want to train on the compliance aspects and do this upon hire and along the point of time of hire. You could even have a period of time of probationary time frames, etc. And then you want to provide annual updates. Coding and billing training should be provided. And again, this can be provided in-house or outsourced. The OIG compliance plan did provide that that this level of expertise or resource could be obtained from an outside relationship. And again, compliance does not have to be a standalone effort. This can be integrated in your overall orientation of staff to your practice and in the development of your policies and procedures. And in fact, it's actually good to establish that way again for your practice culture, and also that sense of expectations and condition and understanding that that's part of the responsibilities and the obligations and expectations for being involved with your practice. Respond appropriately to detected offenses and develop corrective action. You would investigate allegations based upon receipt of notice or reasonable indications. That can be external. You could be receiving something from your Medicare contractor, or you could see a payer denying a number of claims, or you could be receiving an amount of correspondence that's a little bit different than usual about a certain provider, a certain location of service, type of service, or staff involved. You want to take the decisive steps to correct the problem, and again, we just described those warning indicators that you might see. You want to have a process in place for any criminal referral, would that be necessary, and have a process in place for repayment of overpayments, disciplinary process in place, and then when the opportunity provides itself, review the compliance program and to see why this particular issue was missed, and this could be one that's then part of your ongoing efforts from that point forward. Developing open lines of communication with employees. You want to have it established that a reasonable person acting in good faith is able to report conduct believed to be erroneous or fraudulent. And so that gives people the freedom and the opportunity that they can bring these situations to your attention. You want to provide for anonymous reporting mechanisms. Also that provide provisions that failure to report what one sees as fraudulent or non-compliant activity is a compliance violation itself. You want to make the process and the procedures to report accessible and easy to accomplish. If you are doing this with an outside vendor working on your compliance plan, you want to have that communication and documentation for this communication in place as well. You want to provide protection to the extent possible of both the individual who may have had the improper conduct in terms of compliance and the reporter themselves. And at some point in time, everybody probably needs to understand that information could become public. However, you do want to try to have this done on a confidential basis during investigations as possible. You want to provide for a no retribution provision for reporting by individuals, again, who are acting in good faith and reporting conduct that they believed to be erroneous or fraudulent. And then finally, you want to enforce those standards through well-publicized guidelines. The inclusion of guidelines within training and procedure manuals or your human resources manuals, the OIG considers to be satisfactory in and of itself. So again, that's why it's helpful to build this in a sort of an integrative or holistic approach to orientation and human resources. You want to provide and assure consistent and appropriate escalating sanctions all the way through termination are available to the practice. you want to develop documentation of action steps, and that those action steps are documented within your compliance files themselves. And again, you want to monitor lists of those excluded or debarred from federal programs from a recruitment and hiring perspective. What are some of the other sources besides the OIG compliance plan itself? What are some of the sources of focus for compliance plans? Well, you could identify practice identified areas on a routine or ad hoc basis. Again, you may see some issues that have come up with correspondence or denials, and they produce a flag to you. There could be formal or informal quality assurance or risk management activities that develop an area of focus. You could be reviewing OIG alerts, guidance, or work plans, which we'll describe in a little bit more detail. You could also see or review information from your CMS contractors, the MACs and the RAC focus areas. Areas of focus may be brought to your attention by your state Medicaid program or other regulatory process in your individual state. Private payers may be bringing items to your attention, and again, then the issue becomes one of a contractual relationship. And then you might also be receiving complaints or seeing problem areas from staff or patients or caregivers.